Rapid. So welcome everyone, and thanks a lot for joining us. It's my pleasure to introduce Dr. William Stokes, who will be talking about successes and challenges in international medical education partnerships. So Dr. Stokes received his MD from Memorial University in Newfoundland, where he was awarded the Dean's Convocation Award in Medicine. He is currently a medical microbiologist with Alberta Precision Laboratories and an infectious disease specialist at the University of Alberta Hospital. His interests and activities include medical education, rapid point of care diagnostics, and tropical medicine. And to paraphrase his Twitter account, Dr. Stokes has interest in infectious disease, social justice, and making the world around him happy. And speaking from personal experience, I can attest to this last point, as Dr. Stokes, with some help from his dog, Dickie, managed to make our microbiology lectures absolutely hilarious, yet very informative. So I'm really looking forward to learning more from him today. So Dr. Stokes, take it away.
Thanks, Katie, for the excellent introduction. I see that Google has lots on me, which is both great and also somewhat scary. I might have to do a Google search of myself later to tweak that a bit. Yeah, I just wanted to give a touch on global health medical education with respect to the activities that I've been involved with, as kind of getting some inspiration for others to get involved with this, which is a growing field of great importance these days with the increase in technology. So let's get started. First off, it's Global Health Talk. So of course, I'm going to acknowledge that we are situated on Treaty 6 territory with traditional lands of the First Nations and Métis people. Because it's Global Health Talk, taking words and putting it into action by with this talk, donating $25 to the Nijinan Housing Ventures, which is an NGO based here in Edmonton that provides housing to Indigenous populations locally. So I encourage you to check them out. Their website is in the bottom right below. Some other acknowledgements. I recognize that I am a white male born in Canada, so I am given a global health talk. I recognize that I have I was born into more privilege than the vast majority of people worldwide. So I respect and recognize that. Just like many people in global health, I have no protected time for global health activities. Not saying this as a bad thing, just hopefully inspiring people to recognize that it's difficult to get the time and resources to do these activities, but don't be discouraged by that, because many of us in the field have the same issues, and we need to work together to improve that. And then the work I've done was during residency or my fellowship training, and I did my training in Calgary. So a lot of this is Calgary specific with respect to the partnerships. But hopefully now that I'm new staff in Edmonton, there'll be a future talk where I talk more about the partnerships with the U of A. And I have no conflicts of interest, to be clear. So just an outline of the talk, we're going to do a quick intro to international medical education partnerships, what it means, what's the most recent literature on it. I'm going to focus on postgraduate as opposed to the med school level, just to be specific, and then touch on two projects that I was involved in. One was through Georgetown, Guyana, and another in Gondar, Ethiopia. The project in Georgetown I actually started, and then the project in Gondar I was participating in as a trainee. So it's kind of two different perspectives there, and each with their different successes and challenges. And then just a quick self-reflection of each project and how it relates to international medical education partnerships. So just an intro, the world is changing. I read today that 2021 is to 2000 as the year 2000 is to 1979, which is a bit of a scary thought for someone like me who's grown up in the early 2000s. And the world has definitely changed even from the early 2000s to today. For example, this is a picture of me going to Africa, specifically Tanzania in, I think, 2005. This picture gives me great anxiety to show because I'm wearing baggy, bright yellow shorts with a fanny pack and strappy sandals with socks. But I just wanted to highlight this as an example of what the early 2000s was like. You know, I took this photo, I printed it off at Walmart, put it in a photo booth collection. I think I emailed my uncle with the photo. I think a few years later, I uploaded it to Facebook with like my 2 friends that saw it. Whereas today, a quick YouTube search shows this lovely lady who lives and is born, raised in Tanzania, who just takes videos of her day-to-day life, whether that's cooking, cleaning, playing with her child, and so forth, which I think is a great showcase of where we are today with technology and the access to technology in different parts of the world. So much easier today to get a sense of what life is like in Tanzania than it was in the early 2000s. And certainly, you know, you think about 1970s, even more so. Has medical education really caught up to our technology? I think it's starting to, and thanks to the COVID pandemic for getting Zoom and other internet platforms more on the more limelight than it had before, which I think helped speed up the process. But I think we're still trying to catch up with how fast technology is improving life worldwide. So international medical educational partnerships, I refer here as IMEP. For the purposes of this talk, it'll be about, you know, between a developed versus a developing institution. That's mainly because of the there's much more implications involved because you have such a huge power differential between institutions. But just recognize that, of course, medical education partnerships happen commonly between developed institutions, whether that be different parts of Canada, province to province, or internationally. You know, Canada, US is a great example. Lots of collaboration and work being done in medical education with those 2 places in particular. Anyways. And of course, with these partnerships, it is a partnership, so you want it to benefit both parties. So in terms of a developing institution, there's lots of benefits that have been addressed in a recent publication. One of the common themes that comes out is the increased support that a developed institution can provide for providing postgraduate medical education. And the reason for this, similar to what has happened in Canada and other places of the world, a lot of emphasis was placed on the medical school. And so a lot of capacity was given to increase the number of med students coming through the system. But that same support wasn't given to postgraduate medical education. So there was a bit of a gap there with being able to have the resources and support available to help train those increased numbers of med students coming through the system. And what has been shown is that the developed institution does help provide that increased support with respect to postgraduate medical education to fill that need. And then another great thing that developed institutions bring to developing institutions is the ability for training and higher level specialty education. Because, you know, there's only certain places in the world that may do advanced heart surgeries or advanced access to certain diagnostic platforms, what have you. And just having that higher level training, those specialists be able to provide that higher level care, higher level training to developing institutions can provide quite great improvements in those institutions, especially as healthcare becomes more accessible worldwide. Different institutions are gaining huge advancements in their healthcare. And so it helps those physicians locally in those developing institutions get that higher level specialty training that's needed to provide those extra services to their population. And then, of course, as a developed institution like the University of Alberta, we have a lot more funding, a lot more resources available to help provide research and other academic pursuits for these developing institutions, which they wouldn't normally otherwise have. And then in terms of the developed institution, so U of A, what does U of A benefit out of a partnership such as this? A big one, especially in my line of work with infectious diseases, tropical medicine, you're getting exposed to other less familiar diseases. For instance, Guyana, huge issue with leptospirosis, which I've seen with my own eyes down there. In Ethiopia, they have huge problems with leishmaniasis, which is very rare here in Canada. So you get access to those diseases that happen in that you see in Canada, but are basically imported from there. And so people say, oh, well, you're so selfless going to Guyana for training. You're providing the care to that population. And really for that kind, like for an elective overseas in Guyana, it wasn't to provide care to the population, though that's obviously something I would strive to help with. I was doing it for selfish reasons. I wanted to learn about malaria and HIV/AIDS and TB to the degree that you wouldn't normally see here. So always important to remember that there's huge benefits gained with the developed institution as well. And then of course, this applies to both institutions, but just specific to developed, especially in these countries such as Canada that are very multicultural. It's important to have that understanding of all the soft skills associated with practicing medicine, the social, cultural, economic, ethical implications of a disease or a diagnosis, etc. And then the world today, lots of international communication and collaboration, which continues to increase and increase. So getting involved with these kind of partnerships helps foster that. I wish I could get rid of this bar up top, but that's okay. Okay, oh no, I'm breaking the system. Okay, I'll just leave it. So there was a publication by Adams et al. That went through some of the core components of an equitable global health education, which I think is quite applicable to developing an international medical education partnership. And I'm not going to go through each core component. It's a lot of words, but basically the common themes of this is that things are equal. The partnership is not one-sided, which you need to be very careful with when you're talking about a partnership between a developed and developing institution. Because again, that power differential can exert a lot of influence. Important to have the developing institution make a lot of the decision-making, especially for things being done within that institution. And then to remember that the benefits apply to both the developed and developing institution. A huge one with this is academic benefits. So a lot of partnerships are being published these days with a lot of the authors from the developed institution, as opposed to the authors being from the developing institution. So important to keep even those things in mind, because really you want this to be a partnership through and through in all aspects of it, whether that be the publication of an article or if it be in obtaining funding and so forth. So basically the theme of this is to create it as equal a partnership as you can. And other things to think about, one that's related is getting buy-in from the site, because the partnership needs to be as equal as possible. A partnership is very difficult to be successful if all the work and activities is happening from one of the institutions as opposed to the other. So for a lot of these developing institutions, it's important to get buy-in from the site, which can be difficult because just like us, especially when you're dealing with medical education, you're dealing with physicians, nurses, pharmacists, other healthcare professionals who are very busy, who are in a system that's strained at the best of times. It's difficult for them to get the ability to work on these projects. So always important to try and get that buy-in before leaping into something like this. And then there's nothing you don't want to do, there's nothing worse that you want to do than to go into an unfamiliar country, start practicing medicine, waving your university flag without any approval or consultation with your university itself. So always important to get advice from local experts, whether that's your global health office, your PG&E and so forth. The U of A is very fortunate to have this global health program, this department, to help provide that expertise and to steer people in the right direction. So very much recommend that before getting involved with this sort of work. And then I mentioned a memorandum of understanding, which is a legal document that kind of that essentially outlines the partnership that you have between the two institutions. This is the ideal scenario to have because it basically takes your partnership and puts it into words and a legal document, which is non-binding, but still very important. This is a bit higher level and requires signatures from the deans of each university and so forth. So it's not always necessary, but even if you don't think it's necessary for your project, I definitely encourage everyone to develop at least a mock MOU because it will really help guide you into what your partnership is, what are the responsibilities of each party, what are the goals and so forth. So this will help guide you and also minimize any issues that come up as you pursue the partnership. Breakdowns in communication or issues that arise, you can always refer to this document to go over what the intended responsibilities were, and so forth. And then anything with global health, always important to have patience with this sort of work. Here in North America, we're very geared towards work and the workaholic lifestyle, whereas other parts of the world may be less so. In certain parts, possibly taboo to go on your emails after 5 p.m. and so forth. So because of that, a lot of things can happen relatively slow, and that doesn't necessarily equate to failure. So just always important to keep in mind with global health work such as this. So let's dive into one example, the first being a partnership I helped create in Guyana. If you're anything like me, I thought Guyana was Ghana in West Africa. I can confirm that that is not true. Guyana is its own country in South America. And it's a really interesting country. It's quite small. It's about less than 1 million people. It only has one medical school, which is in the capital city of Georgetown here on the coast. But it's interesting. Guyana is actually very similar to Canada in certain aspects. In particular, it's the only English-speaking country in South America. And it's also very multicultural. So it's a good blend between people of Indian descent, people of African descent, Chinese, and indigenous. So because of that, you have a great mesh of cultures and religions. And the food is actually is very good. You can go to Chinese food and then one place, and then the next restaurant is a fantastic Indian restaurant. It's a really neat country, which I never knew much about until I got involved. Here are some pictures of the Georgetown Public Hospital Corporation, where all the action took place with this partnership. Here is it from the street view. Here's a picture of outside the emergency department, which is where a lot of the locals congregate, either waiting for family members or waiting to seek care. And just like many parts of the world, their hospital is quite strained. You can see here beds pushed against beds in this obstetrics unit. I did not take this photo. It's a photo I found online. So obviously huge strains on the healthcare system here, but there has been advances in this, in particular through funding through the Libin Institute, actually through the Guyana Cardiac Care Program. They were able to develop this quite advanced cardiac care intensive unit with, these, almost looks similar to what you would see at the University of Alberta Hospital. And not only the wards itself, but also, the surgeries being done, the kinds of chronic conditions they're seeing in Guyana are starting to advance, people living with transplants and so forth. So things are moving in the right direction. Guyana does have a big problem though. Like I mentioned, the hospital system is strained. To put it into numbers, you're talking about 2 physicians per 10,000 people. Compare that to Canada, it's 2 physicians per 1,000 people. And the Georgetown Public Hospital is 400 600 bed hospital. It only has 3 internal medicine doctors to its name. And that's a busy service, admitting about 20 patients a day, seeing about 100 to 120 patients per clinic. If you compare that to the University of Alberta Hospital, which has about 885 beds, that's a huge discrepancy in the number of physicians available for Georgetown. And interestingly, prior to 2005, they actually never had any postgraduate medical education programs. So all the med students who wanted to pursue specialty care had to go away to either Cuba or somewhere in the US to get that training in order to come back. But a huge problem in Guyana, because it's an English-speaking country, and I think because of its geographic closeness to the United States and Canada, they have a huge issue with brain drain. So here's a chart showing worldwide the percentage of people who leave the country who are tertiary educated, so meaning they got their university degree. This is based on year 2000. This is based on year 2010. As you can see, Guyana is a huge outlier in having a huge number of people leaving the country, well over 80%, which is very unfortunate. And part of that problem is related to the fact that they don't have these programs available in their local institutions. So obviously much easier to leave a country when you've already had to leave for training. So how did this all start? It started with a infectious disease doctor from the States actually going to Guyana and developing an internal medicine program there in 2013. And then there was involvement of a Calgary cardiologist, Dr. Deb Isaac, who I can't thank enough for all her help and work with this project. But she has been involved in Guyana since 2012 related to cardiology and helping form the Guyana program to advance cardiac care through funding through the University of Calgary and the Libman Cardiovascular Institute. So she got connected with with Dr. Cole, who is the IDE doctor running the internal medicine program down in Guyana. And myself as a internal medicine resident in Calgary was always dabbling in global health, wanting to get involved as a resident. So I actually approached my program director about any opportunities, and he actually got me in touch with Deb Isaac. I met with Dr. Isaac, and she told me about Dr. Cole and the possibilities of doing something with the new internal medicine program. And that's how it started. I talked to Dr. Cole. We decided what a great idea with the technology that's available in Guyana to take advantage of that and be able to provide teaching through video conferencing and to make it all resident led to help get the project started quickly. So what happened is that we got Calgary residents in internal medicine and sometimes in different areas like psychiatry involved to provide teaching through video conferencing in Guyana. So Guyana has this room with this dedicated video conferencing system. It's very well advanced, and that's thanks to the Libman Institute for this funding. So we kind of took advantage of that and set up video conferencing here, in Calgary, to be able to do this on the Calgary side as well. So the teaching was done weekly. Our Calgary resident taught a topic. The topic was chosen by the Guyana program. It was usually non-communicable diseases because that was a big gap for them, heart failure, kidney failure, those sorts of topics. We also, in partnership with them, touched on topics that they wouldn't normally otherwise discuss, like controversial topics like psychiatry, which is actually a big topic for Guyana because they have a huge suicide problem, unfortunately, related to ingestion of pesticide. And then we also did other topics that they wouldn't normally encounter, like how to give an effective presentation and things like that. We made this a partnership in that the Guyana students also taught us, and that was geared more towards communicable diseases like Chagas, which they are much more familiar with than we are. And the part of this project did involve medical electives. So for instance, I went down there and so did several other Calgary students. And there was students from Guyana that went and did electives in Calgary, whether that be in cardiology or internal medicine. So just outlining some success with the program. This is just over the first 8 months. We did 24 video conferencing sessions with surveys, 191 surveys completed by Guyana trainees, 16 surveys done by the Calgary trainees who taught the sessions. And basically this graph shows that overall it was well received, with most people recommending the session, most Calgary residents saying that it increased their teaching skills and that they would be interested in teaching again. Important here, the last two columns, both parties agreed it helped them make them more comfortable interacting with doctors from other countries, made them want to be more involved with international collaborations, which I think is a huge success to this kind of international medical education program, you know, planting the seed for further collaboration and communication. Another great success with this project is that it became very sustainable, thanks to the introduction of the internal medicine program, such that medical students were able to enter this program to obtain their internal medicine specialty training, which allowed them to stay in the country and become staff in the Guyana hospital. So retention was hugely gained by implementing this program. And because of that, we were able to decrease the frequency of teaching from weekly to monthly. So basically working our way out of a job, which is great because this was, the other teaching was being supplemented by the new staff. And Dr. Cole stayed for a few years, but left again for the US. And since then, which many years have passed, the program director of this internal medicine residency program is actually now one of the graduated trainees of that program. So great sustainability with that program as well. There were some obstacles faced. It was much easier to provide teaching to the Guyana students and much harder to provide teaching for the Calgary students in terms of the Guyana students teaching them. That's because of the schedule of an internal medicine program in Canada. The teaching schedule is very tight, very well planned in advance. So very difficult to sneak our way in there to teach during half day. We were able to do it, but not common, not very frequent as much as we would like. And then the thought behind developing some sort of group to be involved with teaching by the Guyana students didn't really pan out for various reasons, not yet at least. And then we did have limited staff involvement, not saying that staff weren't involved. We had great support, especially Dr. Isaac, and Dr. Cole, and the internal medicine program in Calgary. But the ideal scenario was for Calgary staff to provide the appropriate teaching feedback to the Calgary students teaching the Guyana students to make sure that the teaching topic was appropriate, the student, you know, was meeting their objectives for how to teach and so forth. That was very difficult to coordinate. It's still an ongoing thing we're hoping to strive for. And then there was logistical issues with electives that I think is mainly due to growing pains, as it's a fairly novel situation back then to have Guyana students come to Calgary for electives. And then we wrote a publication on this work, and we were saying, you know, technology, we had no issues with technology. Other centers had issues with technology, but we didn't, we're perfect. And then shortly after that, we started having major issues with technology. It seemed to be coming from the Guyana side, and it seemed to be related to just small blips of the internet cutting out, which wouldn't normally be a big problem, but it caused the connection between the video conferencing to close. And it was difficult to get back into the system once we lost the connection, and it caused huge delays, and it was a bit painful. But just giving ourselves a pat on the back for this. This was Barb Sparina's idea. But we, back in 2017 or so, came up with the idea of using Zoom as opposed to video conferencing, like the landline video conferencing platform, to use Zoom to help make things more convenient for the Calgary students. And it was much easier to deal with internet blips using Zoom than it was with the video conferencing session. So there was still technology issues, but they were greatly increased by using Zoom. And eventually those technology issues did eventually get worked out with Guyana upgrading their internet connections. So that just brings me to the point of where medical education is going in the future. I think we are always heading in this direction of using things like Zoom to supplement medical education. But I think the pandemic just sped things up faster than it normally would. Video conferencing was being used here in this example with Guyana, but also used frequently in other parts of the province, like satellites, medical schools, whether that is in BC or Nova Scotia, what have you. So still being used, but definitely COVID has brought Zoom in particular to the forefront, easily accessible video conferencing technology. And I think this is obviously where things are going with medical education. And I think it's a huge advantage for international medical partnerships because it helps decrease that geographic gap, which this teaching in Guyana is an excellent example of being able to provide teaching very frequently, which is so novel compared to 20 years ago. Where we are now with Guyana, it's still ongoing. Still, I'm not involved as I've moved cities, but it's predominantly trainee-led still. And lectures are happening twice monthly, which isn't a necessity, but was requested by Guyana because they enjoy the teaching. And everything's going quite robustly. The next 2 years have been already planned. There is some improvements in the feedback forums being designed. The trainees leading the program now are trying to get more staff engaged. So lots are happening for the better. There was obviously, COVID hasn't helped things, especially in terms of the electives. So I will move on to our medical education project in Gondar, which obviously not most people, but people like me, when I first heard Gondar, I immediately thought Lord of the Rings. Interestingly enough, J.R.R. Tolkien, who is the author of the Lord of the Rings books, was actually an African native. And a lot of the places in Middle Earth are actually inspired by places in Ethiopia because they have the same name or very similar names, not just with Gondar being one of them. So where is Gondar? Gondar is in the north part of Ethiopia. Here you see the capital city of Addis Ababa, and north of it is Gondar. Gondar is actually quite a unique city. It's referred to as the Camelot of Africa because it actually has castles due to a unique civilization back in the day that developed these castles. And the University of Gondar is actually very well established. It was the first medical school in the country. It has lots of collaboration with a lot of international parties. Very, very prestigious university. And the town is much like any other typical city in Ethiopia. Quite a lot of people, lots of activity, great coffee, which I can't even begin to describe how amazing it is. So the team that led this, I got involved. It was Dr. Bonnie Metherall who started the project in partnership with people from the University of Gondar. But the main team involved was her, and then myself, Dr. Candice Ripon, Dr. Bayan Masagi, and not pictured here, Dr. Dylan Pillay, all associated with the University of Calgary, got involved. And we're all affiliated with the infectious disease program in Calgary. Bonnie got involved for, well, obviously she does tropical medicine, but she also very much loves the Ethiopian culture. She loves coffee. She loves marathon running. I think when she went to Ethiopia, she felt like she fit right in with that kind of culture. So that led to her getting involved. So it started in 2016, and this was at the request of Gondar University, mainly because Gondar has some very unique tropical infections. One of the main ones being leishmaniasis, which is a huge problem in Gondar. They actually have a whole ward dedicated to managing leishmaniasis. but they don't have any infectious disease subspecialists, and there was a need to increase the infectious disease subspecialty training in Gondar to try and capacity build their site as a leading center for infectious diseases. And there was some gaps in trainees being able to do research. So what we decided to do is come up with a medical education partnership that explored the knowledge gaps of trainees and got them involved with infectious diseases, whether that be tropical infectious diseases or other infectious diseases that are more commonly seen here in Canada. And then we actually took, in terms of the research gap, we decided to apply this concept of patient safety and quality improvement, which is the hot topic these days, and certainly growing both in developed and developing institutions. And the reason why we chose that is because it's somewhat of a low-hanging fruit in terms of providing research, because the research in terms of new novel therapeutics and so forth has already been well described, and this kind of research is instead about providing change management to an institution, implementing a solution that is known to be effective, known to work, and implementing it locally, monitoring the response, studying the response, making sure that that implementation is being effective, and completing that cycle to tweak things as you go to improve the system as a whole. And this, since 2009, has gained huge headway in the global health atmosphere, with the WHO developing a curriculum guideline for providing this kind of teaching to medical students. And the plan is for all medical trainees worldwide to be taught PSQI. So what we did is, in collaboration, came up with an intensive interactive multidisciplinary medical education course. Like I mentioned, it's focused on infectious disease, so this is very subspecialty training. We made it as interactive as possible, and we focus a lot on introducing quality improvement in clinical medicine, because we did, through focus groups and interviews, we did find that there was no teaching being done at the med school level for quality improvement. So a pilot course was initiated in 2016. This was through Dr. Metherall. At that time, the other people, including myself, weren't involved, but it was just a quick teaching session for 3 days with 14 learners. I found overall the program went well, and there was a huge demand to continue it, with some of the main qualities being that it's interactive. Students really enjoyed the different kind of critical thinking and other skills that was provided with the course. And apparently all the doctors love to play Jeopardy. This is a slide from Dr. Metherall. Just a little funny tidbit. I do Jeopardy with my students all the time, and clearly is a universal language. So when we got involved, including myself, that started in 2018 and then continued in 2019 and 2020. In 2018, 2019, the project ran over 4 to 5 days with approximately 36 participants in total, a combination of lecture, small group sessions, and lab sessions. And this time we took the approach, we put everything in writing, we got ethics approval, we made sure to document things with pre and post tests, doing evaluations, focus groups, to try and take this course to the next level, and getting something more sustainable brought into the university there. March 2020, we were also involved. I mentioned this one separately because it was a course that was extended to 2 weeks based on suggestions from the university to do so. And we increased as much as possible the amount of teaching provided by the local staff in select areas such as dermatology, neurology, infectious diseases. And then we increased our focus of PSQI. So here's some students doing a icebreaker, which is modeled on team skill building, where they had to try and create the tallest structure. Here's them going through a lab session that was quite interactive. This student's actually getting blood drawn to check him for leishmaniasis. And then this in particular is showing the students teaching each other, because throughout the course they had to develop their own patient safety and quality improvement project to then present to the rest of the group as a solution of one issue that they've noticed in their hospital. So here's an example of the schedule, which we've had to adjust numerous times. As you can see, there's a 2-hour lunch break, which wasn't ideal, but something we had to do because a lot of students actually walked home from lunch, which could be up to like 30, 45-minute walk. So we had to account for that. We had to start later in the day due to students needing to provide handover and so things. But some things I want to point out to you is this wasn't just the cookie cutter course of infectious disease. We did try to take it to the next level with some of the topics being introduced to these students. One in particular, non-HIV immunosuppression. They're so used to HIV immunosuppression, but let's talk about other kinds of immunosuppression, especially as their healthcare system gets more robust. They'll start to see things, even babies being born with congenital immune deficiencies and living with those immunodeficiencies as one example. And then climate change, for instance, was another big topic that we talked about and its role in infectious diseases. And another pat on the back. At the time, we weren't sure about this, but we were teaching them about emerging viral pathogens, what it meant to take a travel history, what it meant to, if your hospital was exposed to SARS, which obviously now looking back was such a great idea because of the COVID-19 pandemic. So just a shout out for that. I think we might have got lucky with it, but important to remember that some of these topics, which may seem not as relevant, can certainly be relevant, especially when you talk about infectious disease, which is so dynamic and ever changing. So were we successful in these courses? Overall, yes. Here's the pre-test score and the post-test score. For course 1, course 2, course 3. So this is 2018, 2019, 2020. You see a percent increase of at least 25% or so for each. And this is statistically significant. The number of students taught was 17 in course 1, 19 in course 2, only 11 in course 3. And that's because there was a drop in students because of the 2-week nature of the course, which we weren't expecting, but isn't due to the course itself not being helpful, but due to conflicts in students needing to get the time, not able to get the time away from clinical duties as much for a solid 2 weeks, which is unfortunate and something we have to reconsider shortening in the future. So there might be some bias here in this result, but still consistent with what we saw in course 1 and course 2. And there was different trainee levels being taught. Very few interns, but a few, mostly GPs and residents of internal medicine and pediatrics. And what we found is that there was no difference in their score between each other, which means that each student was learning the same amount, or not learning a similar amount as each other. The intern did have a higher level of pre-post test scores, but because there's such a small number of interns, it wasn't statistically significant. And then if we break it down into topic, this isn't all the topics, but this is an example of some of the main topics we taught. Overall, there was a huge improvement in pre and post test scores, with some to pay attention to. Epidemiology didn't have as much of a difference, but that was mainly because of the questions we asked them in the pre and post test score, which were either too easy or too hard, we felt when we looked back retrospectively. And diarrhea, we asked them many different questions about diarrhea, and they're all very good at diarrhea, which, kind of makes sense with living in a place like Gondar, Ethiopia, where I'm sure those medical trainees deal with managing diarrhea every day. And then the biggest pre and post test score was in quality improvement. Again, reflective of the fact that we spent a lot of time on this, and also because it was such a new topic to them. So we're happy to see that huge difference in test score. And we were actually able to get a small number of students who had done course 1. And a year later, when we came back, oh, hold on, sorry. Sorry, this should say course 2. Sorry, yeah, course 2, sorry. This is labeled incorrectly, but okay, hear me out. This is the pre-test score of course 1, and this is the post-test score of post-test score of these 4 students in course 1. And then when we went back a year later, we took the same 4 students and we got them to do the exact same test from course 1 post-test. And we found that the knowledge was retained. Coincidentally, they got the exact same mark, the exact same questions right, which is very, we're very happy to see. Of course, it's small numbers, but at least this proves that what we are teaching them is being retained. And I think the biggest success of this project is exploring this idea of quality improvement to Ethiopia, not Ethiopia, but Gondar postgraduate trainees. Some of the examples they came up with were such low-hanging fruits that we really felt like we inspired them, and they inspired us to get motivated to initiate these kinds of projects. You know, simple things like increasing the amount of hand hygiene on medicine wards was a huge topic that they brought forward. Another one was isolating people some way, somehow with suspected TB in the emergency department, which probably got pushed into the limelight with the recent COVID-19 pandemic. And then even things like improving the communication between the laboratory and medical professionals. So for instance, to get a result from the lab, they have to physically walk to the lab and ask for the result. And they propose, you know, why don't we just provide our phone number to the lab? And if there's a critical result, like on cerebral spinal fluid, the lab can call us about that. You know, huge. Of course, that's standard of care here in Canada, but seems like such a small difference, right? You don't need increased funding to do that necessarily. It's such a small change, which could have such a drastic change and improvement in practice. The issues that we routinely heard from students is that they felt inspired to initiate these projects, but were very skeptical of the system allowing them to make these changes, whether that be the administration, nurses, other physicians, and so forth. They felt like it was a huge roadblock for them to even begin to have that conversation of getting involved. So some obstacles faced with that is, as you might have kind of got a sense of when I was talking about this project, it's very much at the parachute level. We're going in, we're teaching a course for a week, and then we're leaving. And we've really been trying to take it to the next level. How can we make this more sustainable? How can we increase the teaching frequency? How can we get particular students involved, inspired to pursue further training, to kind of build capacity in Gondar? How can we get these students to get involved with these great quality improvement projects that they've developed? And we've been trying, and the buy-in isn't quite there yet at the local level for various reasons. Not anything wrong with anyone at the University of Gondar or in Calgary, but there's just not the ability to push it to the next level as quickly as we would like. And this is still ongoing. And then of course, our last course was taught in March 2020, the pandemic hit. And then unfortunately with Ethiopia, since then, they've not only had the COVID pandemic to deal with, but they've had internal conflict between the north region of Ethiopia and the rest of Ethiopia. So for instance, Gondar is affected. I know the airport was bombed, for instance, so it's very unfortunate, and that has obviously been a huge obstacle for us to get things pushed further. So some solutions that we're currently doing right now with Ethiopia is just buying time to try and engage them as much as we can to get that buy-in that we need to take the project to the next level. You know, redefining our goals, making sure that things are well communicated to the leaders at the University of Gondar. Hopefully over time, some of the students that were involved with the course will now become, you know, are now staff in Gondar and might feel more inspired, engaged to be part of the project to take it to the next level. And then in terms of the conflict, from my point of view, all we can do for us medical professionals is to support the communities in their time of need, not necessarily taking a stance one way or the other politically, as that's a whole thing I'm not going to get into, but obviously the people affected are the people within those communities, civilians. So I implore you to reach out to learn more about it and to consider donating to an NGO of your choice that are doing great work in the region to help with that. Some quick notes on self-reflection of these different projects. I put this picture up as a great example of self-reflection. When I saw this photo, I was like, man, this is the perfect example of how not to teach. I'm like hovering over the students. I'm like, my level is so much higher than theirs. They look terrified of me. I'm like waving my arms at them. So this was a good reflection for me to be like, I should have taken a seat in this instance. And I think a lot of people, especially myself, have this issue, like even just talking to patients, it's always important to get to their eyesight level to feel more engaged, as opposed to feeling more like the person taking control of the situation and more of an authoritative approach, right? So that was one reflection piece of this photo that I took away when I saw it. Oh no. So some self-reflection. Why was the Guyana partnership successful? Lots of reasons, but here's some good examples of common reasons why. We had a well-established relationship already in place. That was thanks to Deb Isaac. That was thanks to Joanna Cole, who developed the partnership, got the resources in place for us to basically just walk in and be able to implement something relatively easy. Huge buy-in at both sites, which was great. It was trainee-led, but eventually that spilled over into staff at the Guyana level, being the huge sole leader of this program, which is awesome to see. It benefited both parties, so both parties stayed engaged, especially the Calgary side of things. There really was a gap in the internal medicine residents having access to teaching, so this was a huge benefit for them as well. And of course, Guyana really enjoys the different perspectives of teaching. And because Guyana is English speaking, there was no major obstacles with language barrier, which you don't realize how much of an effect that has, but certainly successful for this project. And as I mentioned, lots of resources, in particular the technology in place to be able to set up remote teaching. Why was the Ethiopia partnership challenging? Biggest one we faced was the buy-in at the local site. This was due to many reasons, as I mentioned. One of the big reasons is there was a lot of turnover as to who was leading this project at the local site. So the person who initiated it had moved to the UK. The next leader of it had moved to a different part of the province. And then it was just, I think because of that, it was difficult to get true engagement because the local leaders were changing so often that it wasn't clear what was happening. And I think because of that, there was a misalignment of goals being done, which again comes back to the fact that we need to take a step back, get our goals in place, get our communication in place, and continue engaging and reaching out to them to get things back on track. There was difficulty in communication, though. I would argue this wasn't as big of a deal because many people who are taught medicine in Ethiopia are actually well versed in English, both written and verbal. Certainly not as well as Guyana, but not to the point that we felt like there was a huge restriction, though it was a barrier. The biggest barrier, though, when you compare this to Guyana, is the limited access to reliable internet. Very common for internet to blip out all the time in Gondar. Maybe there's a way to get more reliable internet, but we were not able to make that work during our time there. So in conclusions, there is overall huge benefits in participating in these kinds of medical education partnerships. between developed and developing institutions. The key with those kinds of partnerships is to remember that there's a huge power differential in terms of resources, finances, and so forth. So you need to make sure that the partnership is equal as you possibly can, and to get direction and input from the developing institution as much as possible. I also want to give a shout out to any trainees who are listening to this talk. This project in Guyana was developed by myself when I was a trainee. Ethiopia, I participated in as a trainee and had huge involvement. So keep that in mind. This isn't necessarily work that's being done by staff alone. Trainees can have a huge impact, not only participating in these kinds of partnerships, but also developing their own. And it's very common to have obstacles, and that doesn't necessarily mean failure. And that's so important, I think, in the global health realm, especially when things are happening at a slower pace than you're used to always remember that obstacles are going to happen, and it's just a matter of working through them as best you can, and to come up with alternatives to work around it. Just another quick mention of how to get involved. I think this is the easiest thing to do is to reach out to people that you know are involved, whether that be your friends, colleagues, your boss, your program director, the Global Health Office, the PGME office, just asking if there's any opportunities available for these kinds of partnerships. And if not, maybe you should look at developing one based on your previous experiences. I'm sure many of you have had experiences in the global health realm, and could use that to its advantage in developing something unique and novel with the U of A. Huge number of people to acknowledge. I will just big shout out to the University of Calgary, the Libman Cardiovascular Institute, and the people involved with the Guyana program to advance cardiac care, and all the people involved with the Gondar and Guyana projects. And with that, I'll take any questions. Thank you.